I had the pleasure of presenting the data on the real-world treatment patterns and the clinical, economic, and humanistic burden in triple-class refractory myeloma. And so what was important and why was it presented in ASH? First of all, of course, I'm happy ASH accepted it as an oral presentation. This was a session which was dedicated to see how the real-world patients' data pertain to as compared to what is being presented in a randomized clinical trial. So the randomized clinical trial are important for drug approval study, right? And they are all very evidence-based, and the patients are all pre-selected, they should be eligible and things like that. So that is an important aspect of the randomized clinical trial. Then the real world experience kind of tells you what is the uptake of the medicine and what is the benefit to the society at large, and especially also the side effects or the risk for the patients at large in the community. So that's where the balance between real-world evidence comes as opposed to clinical trial. So we wanted to find out what is happening. And the reason choosing the triple-class refractoriness was there are several drugs which are working phenomenally well. One is CAR T-cell, there is one ide-cel which has been approved. Then there is another drug going to come out in the market, which is from Janssen & Janssen called cilta-cel. And then all the bispecifics are very, very active in this segment, okay? So we wanted to find out, without these drugs, what is happening to the patient in the community right now versus what is the new drugs will likely to do for these patients. So that was the background which was selected. Now, a little bit on what is the Connect itself is. So Connect MM is a large non-interventional, prospective cohort of patients who are followed after getting their consent in the community of all the newly diagnosed myeloma patients who are getting the treatment in the community, which is about 84%, and then in academic center, another 15%, or in the federal government, that is a VA facility. So that's another 1%. So there are about 3,000 patients who have been enrolled on this Connect MM clinical trial, which is, as I told you, non-interventional clinical trial, as they are being treated by the local oncologists at these various sites across the United States from September of 2009, until in 2016. But they have been followed up until February 2021. So you have a long follow-up. And we are trying to see what is being accomplished in these particular patients. So in this group of patients, when we look at it, what are the things we followed them for? We followed them only those patients who had been exposed to all three different classes of drug, and then they relapsed or progressed. That's called as the index date. And then we wanted to find out how many patients got treated even more beyond that point, and how many people didn't get treated, and all those kind of information we tried to get in this particular group of patients. So when we look at that, we also wanted to find out their quality of life and how do we articulate their quality of life, so that there are several measures available. One set of measures comes from EuroQol, it is called. So the European Society had organized these quality of life assessment tool. So it is called EuroQol and a 5D, 3L. What is 5D? 5 dimension, 3 levels. So that's what the EuroQol is. So that takes into account mobility of the patient, whether they can do self-care, whether they are able to continue their usual activity before cancer or before treatment, what is their pain and discomfort, and what is their anxiety, depression. Those are the kind of measures. Then in United States, we had our own scale, which is called FACT MM. So the FACT itself stands for Functional Assessment of Cancer Therapy, assessment of patient functionally while they are going through cancer treatment. But also MM was specific to myeloma. So that is FACT MM. So we use the European Quality of Life equal. Then we also use the FACT specific to myeloma in the United States, and then brief pain inventory. This tells you how much pain they have, and they fill out, happy face, sad face. Is the pain getting worse? Pain is getting better? Was the pain helped by the medication? The pain was not helped by the medication. So many. And then the treatment reduced the pain. Treatment did not reduce the pain. So all these brief pain inventory they fill out. So these are the things we assess in addition to, their progression-free response rate, progression-free survival, and overall life expectancy. So the traditional landmark, but also what is the quality of life? Because the FDA is interested to know when they approve a new drug, what is their quality of life? Is it going to improve the outcome of the patient? Because on the federal law is they have to approve drugs which will improve the outcome of the patient. It doesn't say survival, or it doesn't say progression-free, or it doesn't say response rate, outcome of the patient. So the outcome includes even pain relief and things like that. So that's why this was important trial to set the stage. So when we looked at this point of view, then we had about 240 patients out of the 3,000 patients. 240 patients met the index criteria of having failed, been exposed to all three classes of drug, and the cancer has still come back. And out of the 240 patients, 155 went on to get additional treatment. That's about 65% of the people got additional treatment. And a third of the patient did not get any further treatment. So if we look at these outcome of all the 240 patients who met the index criteria, then the additional 150 went on to get more treatment, more or less the same patient population, no major differences. And 65 people who didn't get treatment, how they did, we wanted to see the outcome. And if we look at these kind of things, what treatment did they get? If the new drugs are not included in this study population, patients got the same drug in a different combination. They got, alkylating agent, they got DSEP, they got pomalidomide with carfilzomib. If they didn't get, they got only pomalidomide dex or pomalidomide cytoxan, but not the combination of pomalidomide and kyprolis. So the doctors tried to combine these existing drugs in a different way and gave them, because they didn't have access to new drugs. If you look at them, and in what is the life expectancy of patient once they meet the index criteria that they have been already exposed to all three classes of drug and the cancer is progressing, what is their life expectancy? Your life expectancy in this Connect MM was 8.9 months. Then the question is this real? What do we know? So I picked up to tell in the presentation, I looked at two drugs which got approved in this space. One was selixenor, STOMP trial, and then the other one is Belantamab. So when these drugs were approved, in a randomized fashion, the people who did not get these drugs, what was their life expectancy? If they got the drug, what was the life expectancy? Because these were drug approval, but it was done in this group of patients. Selixenor was approved for patients who had failed three classes of drug, and Belantamab was approved for three classes of drug. To our surprise, we find out that the selixenor and Belantamab had similar outcome for these patients. So that is kind of interesting. So the patient who got more than one line of prior therapy, the median overall survival was 10.8 months on Connect MM, And it was almost the same for patients who got selixenor or Belantamab. But 65 patients, I told you, one third didn't get any further treatment. If they didn't get any treatment, their life expectancy was very short. The median overall survival was 1 month. By the end of 1 year, almost 80% of the people have already died. So it is clear that if you fail triple class drugs, 3 classes of drugs, your life expectancy limited. But if you're able to get more treatment, of course, you live 11 months or so. But if you can't get any further treatment, you are likely to die from this cancer within a year from that time point. So your life expectancy is this. So then the question is, what is their quality of life? So the quality of life continues to go down across. If you use the European quality of life measures, you use the FACT MM, the American quality of life measures, or brief pain index. If you look at all of them, it continues to get worse. Because the disease is not under control, and the disease causes more bone pain, more breakage, causes renal failure. So their quality of life continues to go down. And even if they get treatment, the quality of life goes down. So it clearly tells you that, these people have really poor outcome. If you include everybody, the median life expectancy is about 9 months. If you're able to give more treatment, it's about 11 months. And that's exactly what you get out of getting a Belantamab or selixenor. So those drugs were approved, but it has not made a major impact. We really need newer drugs to help these patients out. And that is the premise why this is an important presentation, setting the stage for newer drugs to be approved by FDA in this group of patients, because the life is limited and the quality of life is terrible. Even if they give the existing drug again, we really need new drugs which works very well.